happens in the family, onset at the young age, and female are mostly predominant than the male. So it can be again classified as classic migraine, common migraine, complicated migraine, and basilar migraine. So what is classical migraine? So classical migraine starts with the visual aura. So it lasts for 20 minutes, usually scintillating scotoma. People will complain, will like there is a त्यो आगोको झिल्का आगो जस्तो झिलिक झिलिक भयो आँखा अगाडि होइन त्यस्तो ब्ल्याक ब्ल्याक भयो. So there is some partial I mean temporarily sudden like कोमा जस्तै ब्ल्याकआउट भएको जस्तै होइन त्यस्तो चाहिँ हामीले चाहिँ पेसेन्टले चाहिँ फिल गर्छ. सो प्रिसिपिटेट फ्याक्टर चाहिँ लाइट हुनसक्छ, साउन्ड हुनसक्छ, एक्सेट्रा लाइक फुड होइन, स्मेल, क्राउड, anything can be precipitating factor. When they precipitate with those things, then they start like visual aura, and then they feel like now I am going to have headache. So it could be unilateral headache or like hemicrania. No, some may feel like throbbing or pounding in nature headache, and it is associated with the nausea, vomiting, photophobia, phonophobia. They might heard some sound, and people like to go to the dark place and like to sleep for a while. Some might need to vomit. You know? Even it will not relieve by some analgesic. So this lasts for 4 to 24 hours mostly. Then it will subside by its own sometimes. Another is a common migraine. There will be no visual aura, but prodromal syndrome are mood change, yawning, like mood swing or patient feel like still sleepy. It could be unilateral or bilateral as well. And there is again association with nausea, vomiting, and this also lasts for 4 to 48 hours. Another is complicated migraine. Complicated migraine comprises like blood supply. This happens with a compromised blood supply due to initial phase of the vascular constriction. So when there is a compromised blood supply in the brain, and then it will give you like the throbbing headache. It's associated with the focal neurological disorder also, and ophthalmoplegia and loss of vision. And another is a basilar migraine. So this also consists of the compromised blood supply to the basilar area of the brain. And usually according to children, there is a aura here is like dumbness of lip, extremities, or ataxia or slur speech, and they feel like a throbbing headache. Another is a cluster headache. So cluster headache related to the vascular headache. Male is more predominant than the female. So this is non-throbbing type, unilateral, cruciating, sharp or deep pain behind the eye. So patient feel like the eyeball is going to come out. Like they have severe pain, and this lasts for 35 to 45 minutes and one to four times per cycle. So this is comes in a periodic cycle in the cluster form. So the cycles are interim. Another is chronic daily headache. So this chronic daily headache could be a mixed type, migraine type, tensional headache, chronicity, and the vicious cycle. So another is secondary headache. Secondary headache associated with a vesicular disorder like hypotension, giant cell arteritis, or intracranial aneurysms, subarachnoid hemorrhages, AV fistula. So these are the causes which could lead to the headache, and these are which are secondary. And there is association with the no vascular intracranial disorders like high intracranial pressure, low intracranial pressure, leakage of CSF, or space occupying lesions. So this could lead to headache. Another is cranial neuralgiasis like trigeminal neuralgia, herpes zoster ophthalmicus, where the nerves are involved, right? So in herpes trigeminal neuralgia, so trigeminal nerve is involved. In herpes zoster ophthalmicus also, the trigeminal nerve is involved. So this could lead to headache. Another associated factor related to metabolic disorders, like in hypoglycemia. So when patient has low blood pressure, blood sugar, or high blood sugar, they feel some heaviness in the head, or light headed or headache in the at that time. So also the thyrotoxicosis may lead to headache. Associated with the some substantial withdrawals like nicotine withdrawals, alcohol withdrawal, marijuana withdrawals, and some drugs withdrawals, so which might lead to headache. Another association is associated with this like cephalic infection or inflammation. So this could lead to meningitis, encephalitis, where there is a severe inflammation inside the brain and meninges. So this has like tremendous form of headache, and also in the cavernous sinus thrombosis, patient feel severe headache, and also Tolosa-Horn syndrome. So another associated with the non-cephalic infection are orbital cellulitis, sinusitis, otitis, pharyngitis, dental abscess, and fever from and cause like vascular dilatation. So in this, like you see, orbital cellulitis, this can lead to headache. So so and sinusitis, sinusitis, you get the frontal headache. Otitis, you get the parietal headache. In the pharyngitis also, there is throbbing headache. Dental abscess, those who have experienced this, they will know that it's a tremendous, like, unbearable headache. So these are all refer headaches, and which in the fever also it leads to vascular dilatation and cause headache. So associated with the head trauma, like if there is a head trauma, then they will have surface pain, subdural hemorrhages might lead to deep pain, and post-traumatic headache syndrome, which might lead to sudden after trauma due to some ingoing inflammation or ingoing subspace occupying lesions. So ocular cause of headache related, we can divide the ocular cause of headache into three categories, like acute headache, chronic headache, and recurrent headache. So acute headache, it has acute causes like acute congestive glaucoma, right? What happens in acute congestive glaucoma? So there will be high intraocular pressure, severe pain in the affected eye due to high intraocular pressure, right? So pressure will rise more than 50-60, no, which is very severe, and this slowly cause the refer pain to the head, and there will be nausea, vomiting, and severe headache. Patient when land up in the emergency, they come with a severe headache with vomiting, right? Another is in the acute iridocyclitis. In the acute iridocyclitis, what happens? There is the iritis. So inflammation is going on inside the eye, iris, ciliary body, and uveal tissue, right? So this might give you severe eyeball pain and then headache as a referral pain. So there will be photophobia, headache, eyeball pain, and so to reduce this pain, we use atropine, right? We use the midretics to dilate the eye to lessen the pain due to hydrocyclitis. And another is orbital cellulitis. When you see the patient with orbital cellulitis, definitely there is a full of the orbital apex space, right? The socket of the orbit will be full due to inflammation. So this leads to referral pain. There will be constriction, vasodilation, and irritation in the nerves, so which leads to headache. Another is endophthalmitis. So you all know what is endophthalmitis, right? So in the endophthalmitis, there is infection and inflammation, both things going on. So these infections lead to pus inside the vitreous and anterior chamber. So this has this when goes on tremendously infected. So it causes the sore in the eye, pain, inflammation, redness, and then this refers to headache. Another is corneal ulcer. So you know corneal ulcer. So cornea is the most sensitive and highly innervated area, right? So it's the most sensitive area of the eye. Whenever even the gush of air can create like tearing reflex in the eye. So when the patient with the corneal ulcer comes, they come in severe pain and watering, right? So this corneal ulcer pain can refer to severe headache. So patient will experience the severe headache with corneal ulcer. And any kind of trauma in the eye, even the small trauma in the lid or in the conjunctiva or in the eye, eyelashes, it will lead to pain. So even the eyelashes stray, or during after surgery, patient will complain pain and headache. Another is chronic headache. So how chronic headache related to eyeball means? So when there is a chronic iridocyclitis. So in the chronic iridocyclitis, patient experience chronic headache, right? There will be pain and headache. So referral pain goes to head and then there will be headache. So in another is primary open angle glaucoma. In the primary open angle glaucoma, if the pressure is becomes higher than the normal, then that leads to headache. Also in the neovascular glaucoma. So patient comes with the eye pain as well as headache. And another is herpes zoster ophthalmicus. You know that in the herpes zoster ophthalmicus, the trigeminal nerve is involved, the ophthalmic branch of the trigeminal nerve is involved. So there will be neuralgic pain, right? So neuralgic pain is it this pain is very severe. Patient cannot tolerate. Even with the antiviral medicine, we add different types of analgesic, codeine, and gabapentin also to overcome this pain. Okay, it's a severe form of neuralgic pain. Another is recurrent headache. Recurrent headache related to when there is some deformities in the refractive error, it could lead to recurrent headache. Like some people might have accommodation problem, so when they try to read, they have headache. And when patient has hypermetropia, astigmatism, presbyopia, accommodative weakness, they experience this headache. So when like patient has to read in the far distance, if he's refractive error or astigmatism, they will lead to it will slowly lead to headache, and that headache is recurrent during if they try to do that same work again and again. And some have convergence deficiency, so some has like difficulty in fusion. That means when they try to see some near object, they cannot focus well. So that leads to headache. So when patient comes with the headache in our clinic, when we try to rule out some organic cause, some other like neurological related cause, when and also the some like vascular cause, we take the detailed history, and we take history about how it occurred, how long was that, and how what type of pain is experienced and time of pain. Then we can differentiate them into different categories. And obviously when they come to ophthalmology, we will do vision tests as well as fundoscopic examination. So in the vision test itself, we can diagnose like what type of refractive error, if they have refractive error or not, if they have problem with the near vision, or if they have accommodation deficiency, or if they have like if their extraocular movement is not well maintained, if they have strabismus. So this all has to be ruled out. Okay, so we will check their refractive error, we will check their accommodative error, we will check that their convergence insufficiency or convergence test, right? When everything is normal, then we will do fundoscopy also to see if the optic nerve is normal or not. Okay, so these are the things we need to do when they come to IOPD. And recurrent ocular headache has a very small fraction in the cause of headache. It is associated with the eye while reading. So this thing I just explained: reading, watching TV, etc. In sustained contraction or fatigue of the medial rectus muscle. When the medial rectus muscle has a sustained contraction, it becomes fatigue. Like when you see close, the medial muscle, rectus muscle has to work, right? When the middle muscle has to work, then it becomes fatigue. So we need to do synaptophore exercise or accommodation exercise to really get relief of this accommodative problem. So this is a referred pain. So this is all about headache. So when patient comes to you with the headache, so there will be multiple causes, right? So patient comes to you with a headache when they have severe headache only. So if there is a mild headache or some like ongoing, sometimes coming comes on and off type of headache, they will treat with the paracetamol. They know that, right? They will try to sleep, but even though it is not relief, it's bothering. It is bothering for a long time. They cannot do their normal work, and then they comes to you. So when people say headache, don't take it lightly. So it could be simple astigmatism to severe space occupying lesion or severe some kind of problem inside the brain. Like in notes is where they line up, right? If they line up with the sinusitis in the ENT ward or OPD, or if they have like vomiting or some other features comes goes to medicine OPD, like if they have some visual difficulties, they comes to ophthalmology. And if they have some kind of problem like a mental problem, they live in the psychiatry. So all of these variable departments has to rule out the other causes also. That's why we have in here in the practice, like whenever they comes to one department, they will refer to other department to rule out cause of headache. Like if you feel like there is something wrong with the sinusitis, we refer them to ENT, because there could be many causes related to eye, ear, nose, throat, and related headache, right? So if there is some sign of neuralgic symptoms, then you refer to neurologist. Or if you see some sign of like hypertensive or some diabetic, hypoglycemic, hypertensive related disease, then you refer them to medicine, right? So this thorough examination has to be done when patient comes for a headache. So headache is a simple word, very common word. Many people use it for many purposes, but when it comes to the patient with headache, that is not the simple word now, because they don't come to hospital for the simple headache. They simply do the all the remedies before coming to the hospital. So every time when patient complain you about headache, there must be something going on. Even the psychiatric, like stress, anxiety, depression. So these are the things you have to rule out. If you don't find any organic lesions, right? Sometimes we might have to do like MRI, CT scan, right? So if you feel like there is something like space occupying lesion, if you see some focal neurological sign like some seizures or focal seizures, that could also lead to headache. So these are the things you always keep in mind, right? That this could be the cause. But if it is not other than some simple cause, then treat it first. Okay, treat the simple cause, then if it is not relief, then go to big causes. But if you see in the first phase, like they have the big problem, they have then you treat that big problem. So always if the headache has a, like if it is due to ocular causes, it will get rid of the remedies. But if it not, if you treat the ocular causes, because if it comes to the ophthalmologist, they will first treat the ocular causes, right? And they also see ask for the another like related or other related causes of headache. So history taking is very important here. Okay, so when you take history, you always consider everything, like every causes, and then focus to one cause. So this is all about headache. Do anyone has any question? I'm not going through the all the diseases we have mentioned here, because we have already gone through this in another lectures. So if you have any like, if you want to know any like this disease, then you can ask. Okay, otherwise we are done for the class today.